Welcome back. Let's Get Physical Therapy is an educational podcast brought to you by MedStar Health and hosted by me, physical therapist Becca Schumer. I will be sharing the mic with tons of healthcare professionals with the goal of educating and inspiring fellow PTs and future PTs. We hope you find this both informative and inspirational, ultimately optimizing how we treat our patients and grow as professionals. Please enjoy today's episode. Today on the podcast, we have Dr. Evan Argintar, who graduated from Georgetown University School of Medicine and then completed both his residency and internship in orthopedic surgery at MedStar Georgetown University Hospital. He completed his fellowship training in sports medicine and upper extremity reconstruction at the Keck School of Medicine at the University of South Carolina before returning to the area to join MedStar Washington Hospital Center, where he is a member of the Orthopedic Institute and serves as the Assistant Director of Sports Medicine. He's previously been the assistant team physician to both the Washington Nationals and Washington Wizards. Since September of 2012, Dr. Argintar has served as Director of Sports Medicine Research at MedStar Georgetown University Hospital Residency, Assistant Professor of Clinical Orthopedic Surgery at Georgetown University Medical Center, and Clinical Instructor of Orthopedic Surgery at the George Washington University Hospital. Dr. Argintar specializes in sports injury, upper extremity reconstruction, and joint replacement. He sees patients with injuries to the knee, shoulder, elbow, and hip. He is currently involved in research of ACL repair, a new surgical technique that may replace traditional ACL reconstructive surgery, which we're going to get into today. Dr. Argintar also played collegiate lacrosse at Tufts University, contributing to his passion for caring for athletes at all levels. When not seeking prospective research in sports medicine, Dr. Argintar enjoys spending time with his family. Dr. Argintar, welcome to the podcast. Dr. Argintar, thank you so much for joining us on the podcast today. Super stoked to have you talk all things ACL.
Thanks for the opportunity. I'm excited to chat.
Absolutely. So we're going to cover a ton of things. Hopefully we can fit all into this 45-minute time slot here. But I want to kick off and just hear your journey to becoming a surgeon and why did you go that route and journey of becoming that?
Well, it starts a long time ago for like a period of 10 Halloweens in a row where I dressed up as a physician. So I always knew that I wanted to be a doctor. I wasn't quite sure what type of doctor. I wanted to be a pediatrician for a long time. I had some uncles in the family who were my pediatrician. My family's pediatrician, and I always liked children very much. And then I went to med school and everything shifted and I like surgery. So I thought about some type of pediatrics surgery, but then I found that included taking care of the parents, which was a little bit less fun. And I found that, as an athlete, and I played lacrosse and rugby in college, that I really had an interest in a familiarity with a lot of athletics and a lot of injuries that occur to athletes. And I found out very quickly as I did all my clinical stuff that being an orthopedic surgeon was the absolute correct fit. And then during residency, when you're exposed to all these, different aspects of orthopedic surgery, I very much like sports medicine because it allowed me to really be as generalized as one can be sort of in an academic environment. And so now I get to take care of shoulders and elbows and hips and knees and ankles. And I like being focused on the whole body rather than the treatment of one joint or one type of surgical management of joints.
Seems like a lot of you and your colleagues were lacrosse players in college.
Yeah, it does.
I wonder if there's a correlation.
Well, I think the correlation is the geography. I mean, I'm from DC, and I grew up in Montgomery County, and lacrosse is popular in this region. So maybe a lot of people just kind of come back, and a lot of people who come back started here and were lacrosse players. But yeah, I agree. I've noticed that we would have a really good middle-aged lacrosse team of you could find some other region to challenge.
And then you guys need to find surgeons to take care of all those weekend warrior injuries.
Yeah, well, that's the downside, and that's why that team doesn't exist.
Awesome. Well, thanks so much again for being here. We're going to kind of jump into the ACL tears. We know they're very prevalent. We treat them a lot. So just curious, how common are they? And we're going to just dive right into that.
Yeah, I mean, they're different. It's a common injury. If you're trying to know, like, how often do they occur in a population of 100,000, I don't know, and nobody really knows. And I think that's, maybe less interesting. It is a super common injury. It is a generally non-contact injury that we see with a lot of athletes who play lacrosse and play soccer and play football. And the problem with it, there are lots of problems, but the problem is that although you don't need an ACL to live, uh, generally athletes who are wanting to have stability, specifically rotational stability to their knee, do enjoy having that ligament. So it almost always, but not always, often leads to surgery. And almost always, I recommend people who want to have stability to their knee, I recommend that they get surgery. And the surgery itself is not such a big deal. It only takes, an hour. The problem with this particular surgery is that the recuperation and the recovery take a really long time. And people have to be compliant, anywhere, between 8 and 12 months. In my training, we used to tell people that 97% of the time you're going to get back to the same level of sport. And what's nice about ACL surgery and recovery is that it's actually the most studied thing in orthopedics. And so, unfortunately, with that excellent level of evaluation and investigation, we have found that those old, more historical numbers were probably a little bit inaccurate. And so that has really fed a lot of research going into all aspects of ACL surgical stuff and rehabilitation. But it is a very common injury.
I don't know if you can speak to this. I know in my practice, I treat a lot of athletes and patients post-op ACL, and it seems like as the years go on, I'm seeing them younger and younger and older. Are you seeing that in your clinic, age-wise?
Yeah, yeah, I would agree with that. I mean, I think that, humans are staying healthier longer, and are as people get older, there is a requirement of strength and flexibility. I mean, accidents can happen, but also as you get older, there's a maintenance that sometimes is followed but often is not. We get these weekend warriors, and I kind of feel like when I look in the mirror, maybe I'm becoming one of those weekend warriors. So it makes me nervous. But people are playing pickleball longer, and people are being healthier and wanting to live lives that are more youthful, and that's awesome. That makes me, as a physician and as an orthopedic surgeon, very happy. And then the other end of that is that younger athletes are getting more focused and more intense sooner, and probably our ability to not only identify but also treat the skeletally immature athlete has changed quite a bit. Expectations from coaches and parents and desires from young athletes has changed, and so I think that the Venn diagram has expanded to take these people who we once upon a time thought were sort of the extreme outliers, and now in 2023, the reality is there's a bigger population, unfortunately, to catch, and who puts themselves in a potential vulnerable position to have these injuries. But I would agree. I noticed that as well.
When you get these athletes into your clinic and they fresh just tore their ACL, looking to schedule their surgery, what kind of conversation are you having with them with regards to like the future of their knee?
Well, here's my generic conversation. So I'm going to pretend like you're someone who's just torn their ACL.
Don't jinx me. Don't jinx me.
I shouldn't say it. I'm wishing it away there. I took it away. The first question is, do you want surgery? And so that looks like, we talk about expectations and interest in playing sport. I give every single person I see the option of not having surgery, which I think is a little bit unique. You don't need an ACL to run or to walk or to jump. You need it for rotational stability. And a true statement is that there are individuals who we call copers, who are, by today's standards, sort of impossible to identify. But there are people who even can play sport and do these things, without an ACL. Now, most people are not them. And unfortunately, the only way to find out is to release them to the wild and to see how they feel. And my anecdotal experience mirrors, others, which is that most people are not copers. Most people will at least feel that their knee is abnormal and funny and wonky. And usually they have instability events, which can, even be dangerous. And I don't use that as a tactic to scare people into surgery, but the people need to know that the ACL deficient knee is one which is less protected all individuals who get an ACL tear, regardless of treatment with or without surgery, are at a higher risk of developing arthritis. And that's a problem that will develop, depending on the age, much, much farther down the line. If there's someone who wants to do surgery, the more controversial thing that I talk about is, do you want an ACL repair or do you want an ACL reconstruction, which I think is an interesting one. Once upon a time, when I first started doing repairs, it was a little bit more on the fringe of orthopedics, because 30 and 40 years ago, people had tried to repair these things non-anatomically, and the success was average. It wasn't a complete failure, but it was average. Moving forward now to 2023, our awareness of even just most simply the anatomy of the ACL, but also more importantly, our ability to repair it anatomically has completely changed with concepts called like the internal brace, which we can get into. But others like myself, and I'm someone who does a lot of research, and particularly on this internal brace thing and ACL repair, which is based on in this internal brace thing. I've had really good clinical success. And so generally now, because I've had this success and it's been mirrored in other people's research, I tell people, if it's repairable, I'll fix it. And if it's not repairable, which is the majority of the time, I'll do an ACL reconstruction, which means I take something from either your body or somebody else's, and I use it to replace your ACL. And so that's usually a very digestible conversation. People say, all right, if you can fix it, fix it. That's kind of logical. Then we talk about the type of graft, which depending on the person can be overwhelming or can be very simple. And I like to start with it being very simple. And I say the following. There are lots of options. If there was one option that was better than the rest, everybody would do it. But that doesn't exist. And so now if you go online, you can find these rabbit holes of people just arguing tooth and nail about which is better. And these are all respected individuals. But when I do them, I don't care which one I do. And I forget every time which one I've done unless I'm looking at the leg, because I rehab them the same. And I think essentially they all do identical as long as you have a hardworking patient who's compliant with a good therapist. And there are autograft choices, which means you take it from their own body. And there are allograft choices, which means you take it from a cadaver. I tell people that if I tore mine, I would get an allograft, which is a cadaver. And the real true advantage of that is that it is of zero pain. And we take it right off the shelf and put it in the knee. For someone like myself who has a wife who would want me most involved in parental care of my 3 kids, she would want me less in pain and more active. And so that's why I would do that. So I could, get back to work and get back to parenting and not skip a beat. It's not uncommon to do that, on a Thursday and back on work on a Monday, sort of limping around. That's, it's not a painful thing. The concern people have about that is infection, and people always worry about rejection, which isn't really a thing, but they think about kidney transplants and liver transplants. They don't get rejected because they don't have blood antigen on them. It's not a blood-filled organ. They can fail just like somebody's own ACL, and we know that in younger populations under the 18, that they're more likely to fail. So in my teenagers, I don't give them the choice of allograft, but in everybody else, I do. I do push my younger patients, certainly in the teens and then in their 20s, towards autograft options, because the true statement is nothing could be better than your own stuff. Although, as long as you're older than 18, everything is about the same. And sometimes people say, okay, fine, just do whatever you think is best. And I like those patients the best because they're just trusting me, and I appreciate that trust. But other people want to dive even deeper, and then it gets kind of, it gets a little bit more complicated. The historical gold standard is one called bone patella bone, which is also, and everyone agrees, is the most painful. And that's my least favorite. But that's the one where someone comes in and says, hey, I want what that professional athlete got. Like, I mean, it doesn't bother me. I'm happy to do whatever they want. But when people ask me for my opinion, I say, well, do your own stuff, but don't do the one that hurts the most, because there's not really a benefit to it. And then you can either take the hamstring, and there are 3 hamstring muscles, and you can donate one to yourself, or you can take a portion of the quadricep muscle, which is my preference these days because it is the least painful of all the options that come from your knee. And so that conversation can take 20 seconds and it can take 20 minutes. And I spend as long as the patients want. And I encourage them to go online and allow me to be the filter for all the gobbledygook that they'll they'll find on the internet, and eventually, either at that moment, which is usually the case, or even right before surgery, we come together and decide what graft is most appropriate. And the most important portion of the conversation preoperatively is talking about expectations, both in regard to pain management, which is something that is particularly interesting to me, as well as just the length of recovery and what people are going to be doing at different time points during rehabilitation. But I let everyone know that it is patient specific. Again, when I was a resident, we would tell everyone at 9 months, you're back to playing sport. It turns out that everyone is different, and that's not a surprise. And some people can get back at 6 months, and some people take a year, if not longer. We do know that professional athletes generally take about 2 years to get back to their pre-injury playing shape. And so I remind everyone that this is, a quick surgery that has a really long recovery. It's a marathon, not a sprint. And if they're able to maintain intensity, which is very easy to talk about before surgery, but very hard to maintain after, they will do awesome. And that is usually the case.
Lots of good information there. Curious about if you have a hypermobile patient, or, like teenage girl comes in, knees are collapsing in, just kind of loosey goosey. Does that sway your decision at all?
It sways my decision with what I do in addition to the ACL. So for my people who are ligamentously lax, those people we know are more likely to fail, especially female ligamentously lax. And so I'll add extra articular procedures. And the one that I like these days, and I've tried lots of different things, there's the anterior lateral ligament reconstruction, which I don't love as much right now. And then there's a lateral tenodesis, which sounds really fancy, but isn't. You take a little piece of the IT band, which is a tendon that lives on the outside part of the knee, and you move that little sliver in a way that gives additional lateral support. And I like it because it's easy, it's minimally invasive. It doesn't seem to affect any element of recovery or rehabilitation. And my anecdotal experience has mirrored other evidence-based papers that have come out over the last couple of years, which show that it seems to be rather protective. And so I do try to identify individuals who are higher at risk, and I do offer them extra surgery with the ACL to try to protect their graft and to optimize their outcome.
I've seen that more often done in a secondary tear or revision. Is that being done more as a primary now?
In my case, yeah. Again, the only thing worse than doing an ACL surgery and recovery is doing it twice. And so I think that, although the majority of people do fantastic after one, if you can decrease the failure rate, it's worth it. And so I started doing those things more for revision surgeries, especially with revision surgeries where there wasn't some other obvious, mess up or malalignment. Yeah, because I've been so successful with the revisions, I started applying that technique to primary surgeries where people were a little bit more at risk.
Speaking of revisions and secondary tears, how common is it to tear either contralateral side or the same side again? And what time frame? What's the danger zone?
Yeah, another super great question where I don't have a specific answer. It is not uncommon to fail. I mean, depending on the literature you look at, it could be, we used to say 1%, but it's probably higher. But it also depends on how you define failure, because, failure could be the graft rupturing, which it doesn't happen so common. But failure could also be, ability to get back to sport and feel confident with your knee. So it all depends on goals, right? Contralateral injuries are also a real phenomenon. It's a little bit higher in our young female populations, which isn't fair, but it is true. And we think it has a lot to do with neuromuscular control and the changes and differences that are intrinsically different in men and women. But every time I see a young female athlete, I tell them that no matter how well you do, there's a chance we're going to be here doing it on the other side, which, again, is a tough pill to swallow and isn't real until it becomes real. But certainly when you see someone who's had a year recovery and they're back a year later for the other side, that's just a big punch in the gut. And I hate those situations, but they occur for sure.
So devastating when we get an athlete and had a great recovery, they look solid, they pass all their return to play testing, they're super strong, solid, they get back, and then boom, the other one tears.
Yeah,
so I've seen a lot of multiple tears in the high school athlete.
Yep.
Are you having conversation? I know you kind of talked about the future of the knee and how having surgery kind of predisposes someone for their knee to kind of have earlier onset of arthritis. But are you also having that conversation regarding maybe this isn't returning to sport isn't the best option for the health of your knee? And how do you kind of help an athlete see that picture acutely?
Yeah, well, I mean, after a primary one the first time, that conversation isn't really a part of it. I think as people get recurrent injuries, that conversation becomes more real. Because people have that experience of like, I've already taken a year out of my life to recover this, and here I'm at as if I've accomplished nothing. It certainly depends on the sport, depends on desires and interest in playing in college if you're a high school athlete. But I think there are two reasons to avoid playing sport, right? One is you have all this other injury like cartilage injury or meniscal injury. Maybe it's not like literally safe because you're going to destroy your knee at an early age and then have long-term issues requiring arthritis orthopedic treatment. And the other is that psychosocially, you just don't want to put yourself in a position to be a little bit vulnerable. And a lot of times it's a little bit of both. But we do know that the biggest reason why athletes don't get back to sport, all comers, is because they essentially have like a post-traumatic stress, meaning that they're just, they're scared. And so, a big portion of recovery to me is not only just physical and orthopedic, but it's mental. And so I will incorporate sports psychology in situations where people have fear avoidance. And, I think it's very easy as an orthopedic surgeon to just care about bones and muscles and tendons. But we all doctors, probably in all disciplines, but, I'm very cognizant of how the brain affects function. And I think it needs to be rehabbed, at the same time. And I think if you fail to identify those individuals who can benefit from that extra type of really psychological rehab, you're doing your patient population a disservice. So that's another way that I work extremely, collaboratively with the physical therapists who are in a better position to identify those individuals at what I call like mental risk. And so I really value that input.
I'm going to have a conversation with a sports psychologist on this. So again, I always say that the person in front of you, like treating the ACL, like that's easy. Like I can rehab an ACL all day long, or patient with an ACL tear surgery, super easy. It's the mental component, the psychological piece that they bring to the table, which is the challenging part, I think.
Oh,
Yep. Awesome. So kind of going back a minute to the internal brace versus ACL reconstruction, how does that affect, for the PTs out there, how does that affect how we rehab them?
so let me just define what that is. It sounds fancy, but it's not really that fancy. It's kind of, to me now, it's a little bit of some common sense. So an internal brace is really just a suture, a really strong suture. It's so strong that like if you're tying it with your fingers, it can like cut your skin. So it doesn't rip in half. You place that with the ACL, and you tension it to the same tension as the ACL, and I'll get into that in a second. But it's basically like a support that runs with the ACL. And the thought is that during this really long recovery, the ACL sort of degrades and gets replaced with your own tissue. And that process is called synovialization. That takes forever. But whether you use a tendon from a cadaver or from your own body, it still sort of falls apart and gets built up. And so there's a period at 3 months where what's in the knee is actually weaker than what you start out with. And that's usually when people are running and jumping and doing things. And so there's, that duality has always been, to me, not making sense. When the graft is weak is when you start kicking it up a notch. And so this internal brace that just simply is a suture that runs with the ACL, we hope that if your knee is put in a position where the ACL might fail, instead of ripping apart, that seatbelt on the inside part of your knee will then pick up the force and protect the ACL. That's all it is. So it's like a little seatbelt on the inside. That's something that I am passionate about and that I have researched. And I'm happy to say I've created some really good evidence that allows, this to be, which was once experimental, now not quite gold standard, but certainly evidence-based. And to answer your question, it doesn't affect recovery at all. I mean, it's a really small, insignificant thing. And for those individuals that have or don't have it, and probably from the perspective of the therapist, most of your patients won't, because not everybody does it. The recovery would be identical. So when I started doing it, and I now do it for every single one of my patients, I've done hundreds of them, you wouldn't know, because I haven't changed my rehabilitation protocol at all.
Post-op, I know different surgeons have different thoughts on this. Just curious, your own thoughts regarding use of the brace, use of crutches, weight bearing percentage, etc.
Yeah, for me, I'm supremely confident about the strength of the repair. So I'm full weight bearing, get rid of the crutches as quickly as possible, get into therapy as quickly as possible. I educate them on home exercise programs in their post-operative discharge um, information, just really highlighting the ability to, or the simple techniques, but techniques people need to learn about to get their legs straight and get it bent. Most people are itching to like jump into therapy, and they're worried that they're gonna, not, they're gonna not do well. And so I say, if you're gonna do something, just work on range of motion. And generally speaking, I do range of motion for 6 weeks, and then, sort of slowly strengthening. But I like it to be very patient specific. So I have different phases of recovery, but they're not based on chronological time. They're based on how people sort of mature and get into things. And so, again, I like to work really closely with my therapist, and they like to work closely with me. And the only reason why I would affect weight bearing status is there's other stuff like a meniscal repair. I'll keep them off their knee for a month. But otherwise, even with the extra stuff, like for that ligamentously lax individual or for someone who's got like a big pivot shift, their weight bearing is tolerated.
Okay, that's kind of a good segue into building a relationship with physical therapists and the importance of PTs building relationships with surgeons and understanding what the surgery was and kind of your expectations. How do you incorporate that, or how often do you want to hear from PTs about how your patients and athletes are doing?
I mean, you should ask my PTs how much they want to hear from me. That's a better way. I mean, for me, I'm like super easy access. So, I work for MedStar, and we have a lot of MedStar therapists who I work closely with, but I also work with a lot of therapists outside of MedStar. And so everybody has my number and everybody has my email. And if people aren't reaching out to me, I don't want to use those therapists, honestly, because they're either worried about bothering me and I don't like that type of relationship, or they're unaware of stuff. I mean, I like range of motion checks early on, and I like therapists to say, hey, Argintar, your protocol stinks, I want to change this. And I say, okay, yeah, let's talk about it. So I think like I think there's a saying, I don't think I made this up, right? There's no good surgery that can't be wrecked by either no therapy or bad therapy. And certainly bad therapists can screw it up, just as bad orthopedic surgeons can screw it up. Okay, but I like a super open, fluid relationship with me and my therapist, because it helps me. And if there are patients who are having problems, I want to know about it early. I'm super aggressive with range of motion stuff. So like my trigger finger to do like a manipulation, which fortunately happens just about never, is if you're not at 90 degrees at 6 weeks, you're getting manipulated. I don't really care, because as stiffness can be forever. Weakness can come back, but stiffness can't sometimes. And so I really value those relationships. I encourage them. I invite therapists to come hang out with me in the office, which I love, so they can see how I think and so I can see how they think. Really, it's an opportunity for me to just, get like in-house PT advice for patients. Patients love it, but it just, I like putting a face to a name. And then I encourage therapists to hang out with me in the OR too, and sort of see what it looks like. Cause I've been told that that's, fairly useful to sort of see why the quadricep gets so weak as you're, blasting a drill through it and stuff like that. And so, yeah, I love that. That is absolutely one of what I think is sort of the keys to my clinical success with my patients are those relationships, which I've strengthened over the last 10 years.
You mentioned the flexion, the 90 around 6 weeks. What about extension? We stress the importance of extension and getting the leg straight. When do you start getting concerned about the lack of extension?
Yeah, 6 weeks is my magic number. I think if you're going to do a manipulation, it's always better to do it earlier. I don't consider it a failure by it. I think therapists sometimes are like, oh, the doc will be mad at me or something. Or patients are worried. I mean, stiffness can happen for a whole bunch of reasons: genetics, certainly compliance, fear avoidance, pain, bad luck, draft choice. I mean, I don't really care what it is. I mean, I certainly tell people that if you're not tough and you can't be compliant, it doesn't matter what I do or the therapist asks you to do, you're going to do average. That being said, some people just kind of get stuck. Some people get nervous early and then realize it, hit that nirvana moment when it's a little bit too late. But to answer your question, I want full extension to at least 90 by flexion by 6 weeks. But most people are, crushing it well beyond that. I mean, when people are flirting around that, usually there's something going on. And so, yeah, I'll do it. I mean, extension is even harder to get back than flexion. So flexion, you can get back a little bit later. Extension, I find, is a little bit harder.
When an athlete's kind of coming up on that 9 to 12 month mark, returning to play, what kind of things are you looking for in your clinic? I know we, as PTs, we have a whole slew of return to play, like hop tests, isokinetic testing, other strength tests, et cetera. But what are you specifically looking for?
Yeah, well, the easy answer is I'm looking for a good therapist to guide me because what I see, I see patients at 2 weeks, at 6 weeks, at 3 months, at 6 months, and I'm lucky if I get the 6 month follow up, right? So usually, I don't know if this is surprising on your end, but usually like a therapist is guiding it more than me because I just don't see them at that point. I see that people are super anxious or doing average, and then I can be more involved. But generally, I want enough time for me to feel like the biology has worked. So like every once in a while, I have someone at 5 months who's like crushing it, and I'm not comfortable with that person getting back to it. But I've had 6 and 7 months. But I want, perfect range or at least 90, 95%. Same with strength. Like I tell people, choose a height above your kneecap and measure the circumference of your quad. And when you're about 90 to 95% of the other side, that's a good sign. I think people feel very good very quickly, but have this quad atrophy, which allows them to be vulnerable in a way that they don't realize. And that's the hardest thing is when you have people who feel good, but their quad is weak and trying to hold them back, but they want to get back to it. I just remind them that second surgery is less fun. And that is usually sort of a strong argument. But to answer your question, it's really restoration of strength and flexibility with enough time. And again, it's patient specific, usually somewhere between 8 and 12 months.
They have an anomaly around 5 months. All those things are looking good. But we know the research says holding them out a little longer is going to be beneficial to reduce the risk of re-tear. Are
Right.
you holding that athlete back, or are you having that conversation, or you're like, you pass everything, go ahead?
It also depends on the patient, right? Like some people are going to go back a little bit more timidly. I like those people better, right? Like they're not just going to belly flop into the deep end. Other people, I know that if I say you can do a little bit, they're going to just be insane about it. And it also a little bit depends on the sport or the position even they play in the sport. So the equation gets a little bit difficult. And so I can't answer that with a yes or no. It just kind of depends on sort of the makeup of the person and, all the stuff that you can't really quantify on paper. I give them a look and I'm like, you're going to be someone who's reasonable, fine, go back to it. Or you're going to be crazy, unreasonable. You're still in the penalty box for a little bit.
As far as bracing, do you use a brace when the athlete returns to sport?
I would say the only non-evidence-based thing I do is bracing. We know pretty clearly that braces don't actually do that much. I give people a brace early on just to help with quad strength. A lot of my patients get a nerve block, and so they're feeling a little bit weak, and so that gives them some stability. But then there's this huge period of time where they don't need a brace. I will get people what's called a functional ACL brace, which I think helps their brain more than their knee, but it still helps their body. And so some people hate it, more people like it, sort of like a security blanket. And I tell everyone all these things, these aren't secrets. And I say, like, try it. You might like it, you might not like it. If you don't like it, I'm not going to lose any sleep about it because it's never been shown to do anything. But for those people who do like it, they really like it.
It's been a great conversation. Starting to wrap up here. I'm curious. I know we talked a lot about a lot of good things. Would be your top 3 tips to a physical therapist? Because this PT is Let's Get Physical Therapy. It's for PTs, right. Hopefully PT students listening. Right. To either be better PTs for patients post-op ACL, better communication. What can we do better as a profession in treating athletes post-op ACL?
I mean, I think that not all therapists are comfortable reaching out to docs, and not all docs want to be reached out to. So I think it would be useful for therapists to sort of figure out what type of docs they have. I would have a low threshold of reaching out to those docs and saying like, hey, can I shadow? Can I see what's going on? For a lot of reasons. One, relationships get stronger, probably get better referrals, right? All those things are good. But I think creating those opportunities are good. And if you get some jerk ortho doc who doesn't want any part of that, and you will, because, we're not all, not some of us are jerks. All right, fine. You tried. But I think that establishing those relationships, a lot of us get just super busy. So like, me reaching out to you and saying, hey, do you want to come hang out with me? Like, I probably won't have time to do that. But if you express some interest, I love it, all day long. So I think that would be a big take home point. And I think if you're identifying that there's a problem with stiffness and things like that, like if you have those relationships, like, I always want to know about that stuff. It's not like I get mad about it at the patient or at the therapist or anything like that. And so I think that's useful. And then once you get those relationships, then you can, like, I want my patients to do better. If you think I'm doing something not good, like, I also want to know, is that a unique quality as me, an orthopedic surgeon, like asking for people to be constructively or not even constructively critical? Maybe, but you sort of figure out which docs are more available to that. But I think most, like, I'm not a therapist, and I don't think any orthopedic surgeon thinks they're a therapist or wants to be a therapist. And so, your insight and experience and training is so radically different than mine, but so incredibly imperative to what I'm trying to do, that, like, I'm working with you all day long. And if I can't, then I'm just at a huge disadvantage.
We need each other to make this happen. We can't do the surgery, you can't do the rehab. So to optimize that patient's care, we got to work together.
For sure.
Last thing I'm going to ask you, what is a favorite quote of yours? We're kind of asking all our guests, favorite quote that has moved you, that motivates you, drives you, not necessarily related to ACL surgery, but just life in general.
Life in general. I mean, I think it's, I work in this crazy level 1 trauma center, so I see all sorts of crazy. Every once in a while I get a normal ACL, but mostly I don't get anything normal. And so I just have to think outside of the box a little bit. And one thing that I think guides me is, like, what is it? The definition of insanity is doing the same thing twice and expecting a different outcome. And so, I've sort of extrapolated that to orthopedics and medicine. And I've always been someone who has never been experimental, but always open to innovative, evidence-based stuff. I was always very fearful to like come out of training and be this awesome orthopedic surgeon who just shuts themselves off from, like, all of the innovation. And so, like in ACL surgery, the way I do it today is totally different than I did 5 years ago, which was totally different than I did 10 years ago. And so I think, you got to be open to stuff in life and in orthopedics and in medicine. And I see so often, because I get all, I'm in this academic place, so I see all these people coming to me for second and third opinions, and I see all these other people who've done the same thing over and over and over and over again, and it's not the patient's fault. And, maybe it's more, guided by the surgeon, but you can't do the same thing all of the time. And certainly if something fails, you can't do that again. And so I'm always looking for reasons why things have worked and not worked, and have then used that experience to, I think, have really patient-specific surgical and non-surgical outcomes. So that's kind of how I do things.
Where can patients find you? Where are you treating patients?
Well, patients can find me just as easily as therapists can find me. So I do everything email, electronic. If you send me an email, you'll hear from me that day. And so my name is Evan Argintar, Argintar, and my email is evan.argintar@medstar.net. And for the therapists out there, if you got someone who, doing average and is looking for another face or another voice, I'm happy to be that person. It's not like I'm just looking for surgical patients. I'm happy to be that person. And I also do things, virtually, which makes it easier. I speak Spanish, which is, I speak it well enough to communicate. And so in any event, I'm available for all patients and all therapists and everybody. And please don't hesitate to reach out. Or if you just want to come hang out in clinic, or if you're a MedStar person, it's even, you can come into the OR these days. I think it's pretty simple.
Thank you so much for your time. This has been great and so helpful.
All right. Take care. I'll see you around.
Thanks for listening to the Let's Get Physical Therapy podcast. Be sure to subscribe to our podcast and follow us on Instagram at MedStar Health PT. If you've enjoyed today's episode, please give us a 5-star rating and leave a review so we can reach more listeners just like you. As always, we appreciate your time and hope you join us for our next episode.